First, we wanted to talk about hypertension-related stroke in pregnancy. Stroke in pregnancy, about 50% of maternal strokes are ischemic, so they're a clot occlusion in the cerebral arteries, and 50% are hemorrhagic strokes. In the general population, generally speaking, 80% of strokes are ischemic. So for our pregnant population, it's a little bit different. The incidence of stroke in pregnancy is triple in the case of pregnant women when you compare that to non-pregnant women of the same age. The incidence is higher in patients with comorbidities, and we'll talk about that a little bit more when we get into the risk factors in a minute. We have seen the incidence of stroke increasing over the last 30 years, and with the highest incidence of stroke during the postpartum period between day 1 postpartum and 2 weeks postpartum. But the risk for stroke in maternal stroke remains elevated up to 12 weeks postpartum. About 1/3 of maternal ischemic strokes have residual deficits, but 50% of hemorrhagic strokes are fatal. Here at VBWH, we have a listing here of the amount of times we activated a stroke code in the last several years. In 2020, we activated the stroke code about 3 times, 2021, 2 times. In 2022, it says 6 times we activated the stroke code. However, there was some data pull discrepancies based on the paging system being down during part of that time. So they said that actually that number was higher, but we didn't know the exact number. 2023, we had 9 stroke calls, and last year they said we had 2. I think that could be higher. This year already in January of 2025, we had at least 3 stroke calls. So we are seeing an increased number of stroke calls in the last several years. Risk factors for stroke in pregnancy, hypertensive disorders remains one of the highest risk factors for stroke in pregnancy or postpartum. Preeclampsia is responsible for about 36% of pregnancy-associated stroke. Advanced maternal age is another risk factor, as well as migraines, cardiac disease, including heart failure and AFib, any of those cardiac arrhythmias that could potentially dislodge a clot and cause a stroke. Additionally, other risk factors are hypercoagulable state like thrombophilia, history of sickle cell disease, and maternal infections. So why is there an increased risk of stroke in pregnancy? There's a lot of physiologic changes that occur in pregnancy that can increase the risk of stroke. One of those being systemic vasodilation and increased vascular compliance that leads to venous stasis and increased risk of a thromboembolism. Then you have changes in clotting factors that increases the risk of a thrombotic event. You also have third trimester, there's pro-inflammatory changes that can contribute to stroke risk. Then you have increased cardiac output in pregnancy that can be associated with cardiac remodeling that increases the risk of arrhythmias. This is obviously a higher risk in cardiac conditions, but it can be at risk, just a general risk. Hypertensive disorders in pregnancy have a 5-fold increase in stroke risk, and so being super vigilant with monitoring those blood pressures for patients with hypertensive disorders. Preeclampsia pathology can cause changes in endothelial dysfunction, as well as producing a procoagulant state and a pro-inflammatory state, as well as a hyperreactive sympathetic state, that all of that contributes to stroke risk. Prevention of maternal stroke starts with treating severe range blood pressure. So when we have a blood pressure reading that's greater than 160/110, we must retake that blood pressure within 15 minutes. And once it's confirmed, it must be treated within 60 minutes. Our rate of treatment here is pretty good. There's always room for improvement, but we do pretty well in treating severe range hypertension in a timely manner. After you've confirmed a severe range blood pressure, you want to notify your provider, and that's a phone call only, not a secure chat. And you want to treat with your PRN nifedipine 10 milligrams PO and then recheck in 20 minutes. If your blood pressure is still severe range, you can give 20 milligrams nifedipine, or your provider may choose to escalate to labetalol. Keep in mind that if you give nifedipine, your recheck blood pressure is in 20 minutes, where if you give labetalol, your recheck is in 10. Follow your orders for when to recheck your blood pressure. Once the blood pressure is less than severe range, cycle your blood pressures every 15 minutes for an hour, then every 30 minutes for an hour, then hourly times 2. And if the patient is pregnant, do continuous fetal monitoring. Symptoms of a stroke in pregnancy are sudden and severe headache and severe hypertension, especially severe systolic blood pressure. We also see other symptoms such as sudden trouble walking or dizziness, loss of balance or lack of coordination, sudden trouble seeing, sudden numbness or weakness in face, arms, or legs, especially if it's one-sided, or sudden confusion, trouble speaking, or difficulty understanding speech. If symptoms of stroke appear, we want to do a rapid stroke screen. So we're going to assess for facial drooping, asymmetry, and severe headache. Assess for arm drift. Both arms would be up together, eyes closed. If there's a downward drift of one arm or the other within 5 seconds, that's a positive screen. We would also want to assess for leg drift. You put one leg up at a time. If there's a downward drift within 5 seconds, that's a positive screen, and then repeat on the other side. Assess the visual fields. You would wiggle fingers in the upper and lower visual fields, so peripheral vision. And if it's absent on one side, that's a positive screen. You would also want to assess their level of consciousness, ask simple questions like, how old are you, what month is it, or ask them to point to the ceiling. If any of these assessment findings are abnormal, you want to call the clerk to activate the inpatient stroke team. The inpatient stroke team brings rapid response to the bedside as well as the neuro team. When we do have a stroke code, the responsibilities of our staff is to make sure that we call our primary provider to the room and call the early warning team, so you have local staff that can be with you and help you in this emergency. Press your staff assist button to get extra nurses to the room. Determine when the last known normal was for the patient. We also need to check a POC glucose and document vital signs and a neuro check Q15 minutes. So you would do a baseline vital sign neuro check and then an additional one 15 minutes later, and you continue that until the neuro team and our rapid response arrive. These two things in blue, the check glucose and vital signs and neuro check, are a requirement of us, and they're metrics that we follow because we're a stroke center. So that is data that is tracked and data that we have missed in the past with stroke codes. We want to obtain a portable cardiac monitor, obtain a crash cart, obtain a stretcher, patient stickers, and prep for transport to CT.